This paper is a great example of poor study design with overreaching conclusions. And the reason I really want to go in depth on this one is because a lot of people are leveraging this to say that kids don't spread COVID to their households or to other people, when we know definitively that that is simply not the case. Kids are one of the major vectors of COVID spread. This was a surveillance cohort study that was done from April 22nd, 2021 to March 31st, 2022, in 11 child care centers in 2 cities, where they did weekly PCR swabbing with symptom diaries and optional baseline and end of study serologic testing, so immunologic testing, where the secondary attack rates and transmission patterns were determined from those diary entries. And this was all self-reported to the child care center directors. So before we even jump into the study, there's already several holes. So when you're doing 2 different cities, 2 places that are very far apart, you're going to have different sets of parameters in each place. These places would have things called confounding variables. Confounding variables are these random parameters that can really influence the results of a study. We could imagine these could be things like ventilation within each school, how big the class sizes are, like how many students are in each class, and then how far apart these desks are. If their lunch periods are individual class sections or entire school events where you have multiple overlaps between different individuals, so lots of student mixing, in addition to the different policies that each city or even a child care center within the same cities belong to. And then you have other factors such as the ability of parents to take time off work to be able to care for children or to keep them out of school when they're sick and things like that. Next, a majority of these are diagnosed for the secondary transmission, the secondary attack rate, through self-reports. People aren't always the best at self-monitoring, so they could miss something like asymptomatic transmission, or they could just forget to report it or write it down or be like, hey, our other child got sick, or this cousin got sick, or something like that. And then starting off with their population size, they have 1,154 students and 402 child care professionals. However, when we break this down, only 83 students got sick, only 21 child care professionals got sick. So our entire study size is 100 for the people that were directly sick, and then for the household contacts, there is only the students that were monitored, since we're looking at child transmission, with approximately 118 adult contacts and then 16 child household contacts. So these are very, very small study size numbers. And again, these numbers are not focused on a single school, which has a low number of confounding variables. It's split between 11 different child care centers over 2 different cities. So when we start to look at the breakdown, this is what it looks like. You only have a couple child care providers getting sick at these schools, and then you have a couple schools that have a lot of people getting sick. So school 1 had 16 people, school 3 had 11, but then on the other side, school 4 only had 2. So when you really start to scratch at that data, you can see that it's not very strong. It's incredibly weak. Now, something that's pretty interesting and is a good takeaway from the study is that students were more likely than child care professionals to have asymptomatic infection. 34% of these children in the study that got sick were asymptomatic versus 8% of the child care professionals, the adults. And then this part right here is very significant, where the household cumulative incidence was about 21%, with no significant difference in the incidence rate between adults and children, showing that adults and children have an equivalent rate of transmitting to household contacts, where the household secondary attack rate was 50% for children and 67% for adults, meaning that these kids are more likely to transmit virus to their parents than to their siblings, even though it's still pretty high, 50% versus 67%. And these 3 findings are the true major findings of the study. However, let's look at what they think the findings are. So because of the 30 household cases, only 5 were secondarily acquired from 3 students infected at the child care centers, they think that child care centers play a small role in COVID transmission in their households, which is really just the wrong conclusion to make, because again, they're working with such small numbers, 5 out of 30, when they're showing that attack rate of like 1 and 2 that bring it home, get their kids, the other kids sick, and then 2 and 3, I think, 2 and 3, 67%, 2 out of 3 kids will get their parents sick. That's a very high secondary attack rate. So the conclusions they draw are like the opposite of what the data actually shows, which is really freaking weird. And when we see different conclusions being drawn from weaker sections of the data versus what they're showing with the stronger sections of their data, That tells us that something else is at play, and that's why we really have to read these studies in depth, in detail, because their studies actually showing that child transmission from a community center or child care center acquired infection is actually a pretty significant level of transmission to households, because kids more often than not are asymptomatic, and they will pretty quickly spread it to parents and other kids.